Inside the upper abdomen, the stomach serves as a muscular reservoir. Food travels down the esophagus, passes through the lower esophageal sphincter, and enters the stomach, where elastic walls expand to accommodate a meal. Rhythmic muscular contractions mix food with gastric acid, gradually releasing it through the pylorus into the duodenum. In a healthy state, this expansion and emptying process is balanced by hormonal signals such as ghrelin, produced mainly in the fundus, which stimulates hunger. Over time, repeated overeating can stretch the stomach beyond its normal resting capacity. The organ adapts to larger volumes, allowing greater intake before fullness is felt. Surrounding visceral fat increases and hunger signaling may become amplified. Elevated ghrelin release reinforces appetite, making portion control increasingly difficult. Before surgery, imaging studies such as CT scans help evaluate stomach size, surrounding anatomy, and fat distribution. Using advanced 3D planning tools, surgeons map a vertical resection line along the greater curvature of the stomach. The goal is to create a narrow gastric sleeve while preserving the pylorus and natural digestive continuity. On the day of surgery, the patient is placed under general anesthesia. The abdomen is sterilized and small laparoscopic ports are inserted through the abdominal wall. Carbon dioxide gently inflates the abdominal cavity, creating space for visualization and precise instrument movement. Through a high-definition laparoscopic camera, the surgeon carefully mobilizes the greater curvature of the stomach. The short gastric vessels are divided with controlled energy devices while preserving essential blood supply. The stomach is fully exposed from the antrum up to the fundus. A calibration tube is positioned inside the stomach to guide sizing. A surgical stapler is then applied vertically alongside the tube. With sequential firings, approximately 70 to 80% of the stomach, primarily the fundus and much of the body, is removed. This transforms the stomach from a wide reservoir into a slender, tube-shaped sleeve. The staple line seals and divides the tissue simultaneously, maintaining hemostasis. The resected portion is placed in a retrieval bag and removed through one of the port sites. The remaining gastric sleeve is inspected carefully. Surgeons examine the entire staple line for bleeding or tension and reinforce areas if necessary. A leak test is performed by introducing dyed fluid through the calibration tube. The absence of leakage confirms structural integrity. Once satisfied, instruments are removed. The carbon dioxide is released, and the small incisions in the abdominal wall are closed layer by layer. Because the procedure is minimally invasive, muscle disruption is limited. Immediately after surgery, the stomach's capacity is dramatically reduced. Even small volumes now create internal stretch, activating fullness signals earlier during meals. In addition, removal of the fundus significantly lowers ghrelin production. Fewer hunger hormones enter the bloodstream, decreasing appetite at a physiological level. During the early healing phase, mild inflammation surrounds the staple line. Capillaries maintain oxygen delivery and tissue edges begin to seal permanently. Over the following weeks, collagen fibers reorganize and strengthen the gastric wall. The staple line becomes integrated within mature scar tissue, preserving the sleeve's shape. As months pass, the smaller stomach consistently limits intake. Meals move efficiently through the preserved pylorus into the duodenum. With sustained dietary adaptation, visceral fat gradually decreases. The sleeve remains structurally stable and blood supply remains robust. In long-term follow-up, the anatomy shows a smooth, narrow gastric tube with intact mucosa and healthy perfusion. Compared to the preoperative enlarged stomach, the difference in volume is profound. Weight loss surgery, specifically sleeve gastrectomy, changes the body by combining mechanical restriction with hormonal modulation. By reducing stomach capacity and altering hunger signaling, it reshapes not only anatomy but also metabolic function through precise surgical design and the body's own capacity to adapt.